So this is the case we took and we kind of modified it out a bit. And it was talking about a 22-year-old woman complaining of neck pain and headaches and is referred for treatment. She gave a history of being involved in this is the wrong case. Let me switch it up. It's a motor vehicle accident. We're going to call this one what she's been involved in. Is basically it's a lacrosse hit. She was checked from behind. And being checked from behind, she was knocked down to the ground, but did not hit her head. Yep. And this happened without warning. And it was 2 weeks earlier. She's experiencing mild posterior right neck ache, and she experienced it almost immediately. By the next morning, the cervical pain had become much worse. It was accompanied by right occipitotemporal headache. The cervical pain and the headache were initially present continuously and relieved only by analgesics. But over the last week, the headaches became intermittent and was only felt upon walking at the end of the day. And the cervical pain was also present at the end of her work day, which really was her school day, and also with prolonged positions such as reading, but she experienced no other pains or paresthesias. She didn't hit her head in the incident and denies being knocked unconscious, and she's able to remember everything about the incident. She had no medical history or relevance of previous neck pain. She did not experience any dizziness, nausea, or visual symptoms. In general, she thought that her pain was improving, but she was able to do more, especially over the previous days. Initially, she took a couple of days off school, then she returned to class, although sitting has aggravated her neck pain, but she's had less over the past few days. So kind of take you through the history and kind of go through this a little bit by line in a sense. We have somebody who was basically in an on-field collision, hit from behind, suffering what amounts to, upper cervical neck pain and irritation. So Tanner, or I don't know if the Tanners are out there today. If not, you there, Tanner?
Yep.
Oh, I'm sorry to hear that for you, buddy. Hey, let's think about this early on. What's your early thought with this case history?
I'd probably be thinking more of like a traumatic arthritis, just given more of like a whiplash kind of type of mechanism of injury. That'd probably be my H1. You want to or am I stating which 3 I think it would be?
You're spot on. I mean, that's what pick an H1 and why it is. And why wouldn't it be something else? What would be at the bottom of that list based on that history? Or next on the list?
I think the next would be more of like a segmental dysfunction. It's probably when I put my H2, and H3 maybe I don't know, like a muscle strain, but that would be kind of lower on my list.
Mm-hmm. What else can we put on the list? And you can just basically list all the conditions that you would think would be relevant in somebody with neck pain.
You could have like a disc, like a fracture, but I wouldn't think it'd be wouldn't think that, but
why not? Not that you're necessarily wrong, but what makes you think that?
The fact that the pain was improving.
Yeah.
I would think with the fracture it'd stay about the same.
Yeah, I mean, there's two kind of contradicting things here, right? Because if we think of the onset of the pain, right? Neck ache almost immediate onset of pain usually suggests some sort of profound structural damage. The fact that it was worse the next day could be indicative of a shock response, right? So the pain's just not as much as it would be the next day once that shock response is kind of worn off, essentially. But the idea then that, the pain has been progressively improving over just the first few days and into those next couple of weeks, that's not real suggestive of a fracture. The other thing is that in somebody with a fracture, especially what would amount to a high cervical fracture, what would you expect their movement to look like?
Very limited range of motion.
Super limited, right? I mean, almost completely braced, they're doing this sort of stuff. So the idea of sitting through class with that sort of stuff doesn't really add up, right? So you're completely right. I just wanted to see that you're processing the information, right? So it makes a lot of sense.
Yeah, that's kind of why I thought I was more with the traumatic arthritis for the H1, just based on like the pain response over the first like week or so.
Well, and the other thing is even with the traumatic arthritis, how long does it typically take for inflammation to build up in a damaged joint?
Well, I'd expect it within like 24 to 48.
Yeah, I'd say somewhere between even 12 to 24, but typically by that next day, the pain's going to be worse, right? The initial irritation. I mean, you get this a lot with people that have, sprained their knee or sprained their wrist, something like that. They can kind of get through whatever they're doing, get to the end of the day, and then the next day it's like, oh, this thing was a giant balloon now. So that, again, from a perspective of looking at the information you were given right there, how does that add up? It adds up pretty well. Sorry, Dave. Didn't mean to cut you off.
No. By all means, that's what we want to do. That's exactly the process we want to go today is pick these out and kind of take a look at them. So Tanner, it looks like you did pretty good compared to my list. Actually, I'd add fracture in there. I didn't put it in there, but it should be there in the key subjectives.
I missed a few, but I missed a few.
Yeah, but you were on your way. I just kind of scrolled down a bit, but you kind of differentiated. Okay, muscular. We have ligamentous. You have disc. We have segmental dysfunction, which you could be looking at, and that could be, we could be looking at hypermobility, or most likely an articular restriction. And the one in the middle there would be the traumatic arthritis, which we call joint inflammation. Concussion and fracture. So, when we do this, your H1 here was basically joint inflammation, and Eric spoke to that. So how would you look at this if this was a joint inflammation? How would this case kind of present to you in your mind?
I mean, kind of how the patient was like presenting with kind of like a traumatic onset, pain that's typically worse either like later that day or the next day, and then like gradually improving but still having symptoms. I guess I didn't know how far we've seen, like how far out is this? Are we seeing her?
This is 2 weeks.
Yeah, I mean, that's kind of like what I would expect them. But like with this case specifically, I think the onset, and then just like how her pain is presenting in regards to like severity, and then also the improvements over like the last week and the onset of it, I think is kind of fits that.
How would this explain the headache?
I mean, you could have like I don't know. I don't think you would have I don't think the facet referral refers that high, or it doesn't refer into that area. So I don't think that would really account for the headache. So I'd be kind of the outlier.
Which one could? If it were.
Like which facet?
Yeah.
I think it'd be the OA joint.
Yeah, you'd be looking at probably upper cervical. So it wouldn't, the headache wouldn't eliminate the joint inflammation or traumatic arthritis. You're just generally thinking, if you're getting the referral and the headache, that you're probably talking maybe C3 and above as your more likely scenario, unless you have something below it, creating a dysfunction at C3 and above, and then it's secondary to, maybe a flexion subluxation below it, creating an extension subluxation above it, but that's probably less likely, my mindset. So for joint inflammation, what would be your objective tests? Like, you want to go right to it.
Yeah.
What would you find on that?
The main thing I'd be looking for is just to confirm that would be more range of motion. Did it say if it was you said it was right-sided?
Yeah.
Yeah, so anything that would be closing down, so like right rotation, extension, and right side bending, I would expect to be painful and limited, with like possibly alleviating in like the left flexion quadrant would possibly alleviate it. If that wasn't positive, I wouldn't like totally throw that out.
Okay. How about testing? What do you think this joint would feel like? Let's say pivum or pavum.
It'd be more of Probably like a spasm end feel with it.
Could be another one. Actually, it could be two more.
Yeah. Yeah. I really wouldn't think of like a capsular restriction with that, but I could be wrong.
Probably not long enough.
Yeah.
We talked about
yeah,
this. We talked about this in the peripheral course. The idea of a boggy end feel.
Yeah. Okay. Yep.
Right. And I think what we talked about is, and again, this is just my hypothesis on it, is I feel like finding a true boggy end feel is going to be a very rare thing outside of like a knee. Just because I feel like if the joint is that swollen and you're trying to move it, the first thing that's going to happen is you're going to get spasm instead. You're never going to get to that hydraulic feel where you're getting the pressure on all that fluid. You're going to get spasm before that kicks in. I think you probably can get a capsular end feel relative. I mean, after 2 weeks, I think that'd definitely be possible. If it was just a day or two in, maybe not. But I definitely think that the capsular and spasm are probably the two most likely you'd run into.
Yeah, I think sometimes you may bump into a boggy end feel, but what you're probably picking up is multifidi hypertonicity, and that area will just feel rounded and protruded more. So as you go out and palpate that area, it'll have a little size difference. And I've seen it described as boggy, but I've often kind of alluded to that too. Do you have like local muscle guarding, which would be that spasm potentially around the joint? But you know what you probably don't have if it's a subluxation, and you may not even get to the end of a subluxation with pivot and pavlik if you have a spasm.
Here's a quick question, and anybody can jump in here. Tanner, you don't have to be, handling everything, but if we're going through our range motion testing, which I do think is appropriate, it's probably your best bet. And say we're going into right rotation, right side bending, which is what you mentioned. What if it doesn't reproduce the headache? Then what are we thinking? Any ideas anywhere? Come on. Somebody's got to have some idea.
Right, somebody's got to be bring on the discussion board.
I can
on keyboard warriors.
Real quick.
Boy, Drew, what you got?
As far as like an irritability goes, it could be that it needs more time in that irritable, position to create the headache. I've seen that the headache doesn't initially come with the neck pain, but if you're in a certain position, so sitting at school on a desk, then after the neck's been bothering you for a prolonged period of time, it then develops a headache.
Yep. And that's, so let me ask you this then. What is that more indicative of based on the list that Dave has here on this left column? If it requires more either sustained position or repetitive movement into that position, what is that more suggestive of?
I would say then it would be more of a hypermobility.
Compared to the traumatic arthritis.
Correct.
Yeah. And I think you're right on with that. And that's why I asked the question is, if the pain is not, if the cervical headache, so essentially the reference is not being reproduced with movement, with the inflammatory reaction, you'd probably expect it to happen relatively quickly, right? Even with the first one or two movements, right? So even just having them turn their head and then try and produce a side bend, that would probably be enough to reproduce the reference into the head if the joint is significantly inflamed. If it's not, and it requires repetitive movement or requires a sustained positional hold, you have to start differentiating those things on your list of possibilities there, right? Moving more toward the idea of this segmental hypermobility, irritability, that sort of thing. So it does make a difference, right? And Jim will do this to you guys, almost guaranteed he'll do this to you guys. If you have a situation where you can't get them to reproduce the headache, you have essentially isolated headaches, different, outside of what's going on with the neck, he'll throw that in there just as like a, what about this headache thing that you're dealing with? Because unexplained headaches are bad news, right? That's stuff that we don't want to have. And headaches in general, they have almost an inverse relationship to the severity of the injury. Typically something that is more biomechanical, more segmental dysfunction, that sort of stuff is going to have a more severe headache than something like a bleed, right? Things like that. That just tends to be the way it works. But I mean, if you can't explain it based on your diagnostic criteria for what you're finding with the actual neck, then you have to put that in, you have to take that suspicion and really put that to the forefront, because essentially you're dealing with something. Then if you can't explain it, you can't say that it's not something, significant, something like a bleed, something like a vertebral artery issue, something like a, post-concussion, something of that sort of nature, right? So gotta make sure that we're taking that stuff into consideration as we go. But good, very nice.
It kind of leads in. We're looking at joint inflammation. I mean, it kind of plays off well against like a segmental, dysfunction. We're looking at hypermobility. Like Tanner or Drew, like what would be the key thing that you would look for maybe in a subjective that might strengthen your hypothesis for the hypermobility? And then, we talked about the pain, probably with the P-PIVM, because it'd be with the motion where you get the pain, and then you can check the end feel, and your end feel is certainly going to be kind of loose at that point if you did it, but you may not actually get into a PAVM if you find that, okay, you don't have a jam joint, it just keeps going. How would you describe your key subjectives, and what would be your objective tests to differentiate the hypermobility?
With hypermobility, a lot of times I'll ask if there's any, clicking or clunking with head and neck rotation, flexion, extension, those types of things. I think I've seen that a fair amount, that they're like, yeah, I just get this like clicking in my neck when I'm looking around. And usually that'll bump up higher on my differential list. What was the second part of your question?
Yeah, we're just looking for subjective and objective. Again, think about if you have to ask a few questions to strengthen what you're thinking, and then if you're going to test this, because you think, okay, this person maybe have some hypermobility issues, and everyone else feel free to chime in on the discussion board if you don't have a voice.
As far as like objective, I mean, my end feel, if I can get there, a lot of times I think with a painful hypermobility, it's going to be more of a spasm before I can get to a true end feel.
Yeah, I put history of, or I look for tendencies toward hypermobility. Where you're talking Braden scales, or just sometimes you get the individual, look at them. Okay, you look at the elbow, and okay, they have hyperextension and large abduction angle. They have these other tendencies. Will do it. The clicking is an interesting one. I'd like to get Eric's opinion on that one. I think you do see it. I think it oftentimes, if a joint is inflamed, whether it's a knee joint or a facet joint in the cervical spine, you'll get a lot more clicking and popping. It can occur with a mild inflammatory arthritis or something like this. So she would certainly possibly have some clicking. If we're looking at a joint inflammation, that would be related to this incident and could eventually go away. Your thought on that, Eric?
Yeah, I mean, the problem is that the inflammation, it's going to alter the axis of movement of the joint, right? So if it's not so significant that it's going to lock the whole thing up, which is definitely possible. I mean, essentially you're looking at joint planes that should be moving like this, but now it's all distended. Will that even move, right? Because you could have things that have done that, you could have things that have done this, you could have things that have just kind of ballooned open. So maybe that takes out the idea of having that sort of stuff, that sort of joint sounds associated with movement. The one thing that we have to always consider when we're looking at the neck, though, is we're dealing with 4 joints total, right? We do have both uncinate joints as well. So if you have that sort of abnormal joint axis from an inflamed facet joint, for instance, you could have abnormal movement patterns through the uncinate joints as well, which could, in theory, create joint sounds. And anytime a joint moves abnormally, the surfaces are going to have these irregularities to them. It's just not going to be, it's not going to be as smooth as what it should be. The friction coefficient should change with that sort of stuff. So I see that a lot. I do tend to have that, but it has to be more of a subjective thing for me most of the time, because it's just not, it's not obvious enough to feel it. When you're moving somebody's neck around, you almost have to ask them that question specifically. It's like, when you do this motion, do you feel any clicking or clunking, anything like that? Or when you're moving them around passively, doing your pivums and pavums, are they feeling these same sorts of things? It's too murky for me to actually have a objective finding of joint sounds. That almost always has to be a subjective finding.
Yeah. Anything else in your differential for segmental hypermobility? Do you think about Eric, Tanner, or Drew? I'm sorry, in the objective. Again, generally at that point we're manual therapists. We want to go in there and see what it feels like.
Yeah, it's just going to be increased mobility at the end feel. I mean, in order to diagnose it, you have to get that, right? So if it's an irritable hypermobility and you're not getting there because of spasm, you can't say it's a hypermobility. You can just say it's an irritable joint, right? So it's the ones that are non-irritable. Those are easier to find because you can actually go through take your joint down and you just say, boy, that's feeling really soft and feels really kind of more mobile than the one that's below it, or the two that are below it, the one that's across from it, that sort of stuff. So again, that's just one of those things that can be a little confusing for therapists when you're looking at that, because it doesn't feel like it's moving much. But if you're getting spasm, it's probably restricting you, keeping it out of there. You just can't make that diagnosis because you can't feel it.
Mm-hmm. Right, Tanner. Again, we'll go an easier one here. We'll go segmental dysfunctions. And since we're in the segmental dysfunction, looks at articular restriction. Let's bang this one out real quick, and then we'll get into a differentiating ligament versus muscle.
So for like the subjective, I would like same thing. If it was more of a restriction, I'd kind of similar. I'd expect mild to moderate referral and pain level. Restrictions with pretty much the same as the joint, as the traumatic arthritis, just limitations with the motion, specifically like right rotation and extension if we're looking at the facet joints. And then like in the objective testing as well, I'd expect the same thing, like a pathomechanical or a jammed end feel. If we can get to that, if it's still pretty acute, you might have a little bit more like muscle guarding with that.
And would a segmental restriction cause a referred headache? Could it cause a referred headache?
I'd say probably not.
I'm tricking you.
I mean, if are you saying like that segment specifically causing a headache, or like are you saying could it cause a head like a
the segmental dysfunction cause a cervigenic headache? A restriction, an articular restriction in the cervical spine cause a headache.
And think of how it would have to have been caused in this situation.
I would say yeah, but I'm having a hard time like taking that.
Because you already said no.
Yep. Already anchored down to the no.
Well, so think about it. What happened to this girl, right? She gets hit in the back, probably whips her head back and forth as she goes to the ground. So if there is a subluxation here, it has to be a traumatic subluxation, right? And we see these things all the time. You ever have somebody come into the clinic with wry neck and just woke up with something like that? Happens I mean, it happens for me twice a month at least.
Mm-hmm.
You know, where somebody comes in and they're sitting there and their head's like this, and they're like, I got to travel today, and I can't even, I can't turn my head at all. Even those can cause referenced headaches, right? So it's the traumatic portion of it.
Mm-hmm.
But when we're thinking about subluxation, particularly of facet joints, what we like to envision all the time is this joint going wham and getting subluxed into this position, or wham getting subluxed into this position. What we have to take into consideration is that we can have subluxations that look like this, right? Or that look like this, where we get a impingement of a meniscoid structure, or even the joint capsule itself getting pinched within the joint articular surfaces. So it's hard to sometimes imagine those sort of scenarios because we're so used to the idea of things looking like they're just off the end of the rail. Unfortunately, the rail's it's not just a two-way street. There's 3 dimensions that these things can move in. And then you have to take into consideration the adjacent structures as well. So some of that sort of stuff can be pretty painful when it does. So yeah, I mean, I think it's definitely possible, mostly because I see it all the time.
Yeah, I'm rooting for it.
Yeah, that's something you can fix pretty quick.
You know, they're hypermobile, and you know, my heart just drops for them, because many times if this is a hypermobility and you find it, then this is often the stimulus for chronic headaches. Sometimes with these hypermobilities, they get this initial episode, whether it's the on-field injury or it's the car accident, and it stimulates this hypermobility and it creates an irritable condition that now is a pain producer for them, and it can be chronic.
Yeah.
So oftentimes the car accident patient, this individual, this is one of the ones you can see all of a sudden they now have a history of headaches. They have a history of neck pain, and it all stems back to usually a singular event or a trauma that kind of precipitated it. It's usually someone that's a little more lax that I'll see it in. So I am hoping for an articular restriction that is not hypermobile or extremely hypermobile after I manipulate it.
Yeah, it's a tough sell when it's the hypermobility, because all you can do then is try and improve everything else in the kinetic chain. Right. So if it's hypermobile into extension, you got to do your damnedest to make sure everything that's going to draw that joint into extension. Right. So in this case, if it's, you know, right rotation, right side bending, basically everything that extends the right side, you got to make sure everything on that right side extends very well.
Yeah.
Right. Everything that helps to rotate to that right side rotates very well. You know, and conversely, that everything on the left side opens very well. Right. So anything that can cause increased pressure into a hypermobile segment. I saw 2 of them this morning. I mean, there were lumbar spine ones, but both of them had rotational hypermobility, you know, what I would call bordering on instabilities at L5. And it's just like, yeah, that's always going to be there for the most part. I mean, we might be able to get it to tighten up some with, you know, particular guided exercise stuff and, you know, taking pressure off of it, but it's always going to be vulnerable. So yeah, it's a tough sell. But yeah, you're kind of crossing your fingers that you've got one of these traumatic subluxations. Although there are some specific things that you have to talk to the patient about when you have those sort of things anyway, because the manipulations are very effective, but in most cases it's uncomfortable to do. One of those rare cases where you're willing to manipulate through pain.
Mm-hmm. Yeah, it's like the stars. Once I'm there, stars have to line up. I've got to feel it. I've got to know it. I got a good sense of confidence I'm going to get it. There's not a bunch of other things going on. Yeah. It's got to feel right and test out right. And then, you know, their willingness to kind of do it. And then me not to muck around with it and be quick about it.
Sure. Well, and that leads us back into our other thought processes, bias, you know, bias reduction, that sort of thing. Yeah. So looking at the top end of this list here, with things like ligament injury, disc herniation should be relatively obvious. But even things like concussion, things like fracture, being able to go back and do a bias correction test at least for each of these sort of things. So what do we got? Let's start with ligament stuff. What ligaments might we have to really look into before going in to do a manipulation for a segmental restriction.
I'd want to look at like alar ligament.
That's a good one. Not the most important one.
Transverse.
Yeah, that's the big one.
Yep.
Right. That's the one where you could really cause some problems. But yeah, I mean, for the alars, here's what the alars typically are designed to do. They're designed to help function that OA joint with contralateral coupling, right? That's really what they're supposed to be doing. If they're not intact, it allows the OA joint to suddenly rotate and side bend in the same direction, which is not good for the vertebral artery. Right? Increases the tortuosity going across the vertebral artery, the stretch that goes through it. So that's something that you definitely want to check for. The other thing is, if you have a sprained alar ligament, that can absolutely cause headaches, right? And it'll happen with movement of the neck. So you got to make sure that that's relatively pain-free before going through and doing that. So yeah, those two for sure. Anything else? Anybody think of anything else? Probably nothing else is essential, right?
Yeah.
If you've diagnosed the segmental dysfunction, the restriction in segmental dysfunction as the pain producer, you're really just going back to make sure that there's not secondary painful structures here, right? So, and again, that's what bias correction is you've made your diagnosis, but you're looking at it thinking, well, what if there's also something like this, right? Because that's the curse of being a physical therapist. In the physical world, you can have more than one thing get damaged in the same incident, right? That's why muscle sprain is one of those things that's just like, yeah, but if I have enough pressure, enough force to damage the muscle, what else did I also damage? You know, that's part of the game there. You have to start thinking that it's also probably damaged the joint capsule, which is closer to the axis of movement, all of that sort of stuff. Same thing with the disc, is potentially some of the annular fibers. So again, it's possible to have more than one thing. And that's one of the things that we have to check for with our bias correction, is making sure it's not more than one thing.
So with this one, yeah, I would say alar ligament would be, if you find this is, if you think about something, talk about the upper cervical sprains that may go on with concussion. And I think there's a high incidence of increased headaches with alar ligament strains in these individuals, and finding laxity. And you'll find these sometimes years later in the frequent headache patient who may have been in a car accident or had something. I've bumped into it here and there over the years. It's not everybody that walks into the clinic for sure. It's you'll find it in some of those individuals who have had these chronic upper cervical strains and injuries and concussions, getting diagnosed with upper cervical sprain. These is one of the things eventually, before they start to return to sport program or different things, I'll get a sense of the integrity of these ligaments. Because if she has let's say you have a lax on the right hand side, but what happens when you go head to head a ball? How many times are you going to do that before you get your head in a funny position? And now you're going to take the force at an angle where, if your muscle timing isn't on correctly, where does it transfer the load to the ligaments? And does that person then re-sprain? So it's something that I like to have in the back of my mind, especially if she's the girl. In this case, she's, I think I was lacrosse, but I think I left it open where it could be soccer. Just to get my point across.
What's that?
I don't know. I can't. Who was that? That was Isaac. He's into drama.
I guess so.
So yeah, go ahead, Derek.
Well, I was just, curious how everybody feels about doing like a sharp purser on these sort of patients, that sort of thing. In theory, that is a ligament test. Now, it's not a stress test because we're not actually stressing anything, trying to relocate. But what do we think? Any thoughts? You can type it in, unmute, throw it out there. Doesn't matter to me.
It's always a thing. You do the sharp purser many times when you don't know any better. Then you reach a period where you're scared about it, and then it could be kind of where I do it. many times at the very back end just to document it. I'll use it just as that I'm 100% convinced it's not it. But many times when I write my note, try to write it from the form of bias correction. Why do I not think that this is a disc herniation or a muscle strain or, a hypermobility? So if you hopefully you read my note and it's like, okay, I can see where Dave's thinking. And then within this note, he's checked for these things in a couple quick sentences.
All right. So here's Marissa gave us a response saying if she was confident it would be negative, then you'd do it. Well, what's a positive test for sharp purser? Excessive movement, right? You'd actually feel it kind of clunk back into place, but in theory, you'd actually diminish symptoms if there were any. Right. So doing it even in a situation where you have a thought that it might be positive is actually a good idea. So my thought on it is, sure, why not? I mean, if I'm doing a transverse ligament test and that's negative, then I'm not going to worry about it. But in theory, the sharp purser is actually the safer option. Does that make sense to everybody? Because essentially what you'd be doing, we've got our ring here, right, with the dens in there. So my transverse ligament test is going to push that into the middle of the canal, whereas my sharp purser test is going to push that back to where it belongs, right? Increasing the size of the canal. So it's one of those things. It's just like, well, yeah, if I do that and I'm doing that test here, right, fixation and pushing back, and there's some sort of clunk or shift or something like that, then I'm thinking, okay, well, I didn't do anything that's potentially harmful for this patient right now. In fact, I've probably taken them further away from a spot that could be potentially harmful. And at that point, I'm done. They're going in a collar and they're going to the doctor. I just wanted to see what everybody's opinion was.
Yeah, it's a point at Jim's. Jim will, if you do a oral practical with him, and then it's be a point of his contention. So look at the sharp purser versus the translation test for that exact reason.
Mm-hmm. Yep.
I think
Jim uses it a lot.
There's better. I think there's better numbers with the two, but I'd have to look at that to confirm it.
It is still considered the gold standard, from what I understand. So, okay, yeah. I mean, the only other ones that I can really think of, tectoral membrane, lanoaxial membrane, atlanto-occipital membrane, those sort of things. Those are really more linear tests. They're not necessarily for true instability.
Yeah.
Basically either a posterior translation of the OA or an anterior translation of the OA, that sort of stuff. So we're probably good there. If you go through to do the ALARs, do some version of the sharp purser or a transverse ligament test, I think you're good at that point. Again, we'd have to be looking for things that are congruent with pain production, right? Because that's what we're testing for.
We have a question about vertebral artery. Here we're looking at upper ligament sprain tests. Really had, we can really put vertebral artery down the list on this. It would come into play if I was looking to manipulate C1 on C2, C2 on C3, or something upper cervical spine or somewhere in there. Then you're probably into your vertebral artery tests. And, we'll look at that too, and also looking to do any cranial nerve signs or symptoms or anything changing with that. But I don't know if I wouldn't put vertebral artery injury necessarily in my differentials here because I can't really test it efficiently. But I will try to test it before I manipulate the neck in an upper cervical trauma patient.
Well, and again, you have to look at it from a perspective of what is the symptom that's making me think it's vertebral artery related, right? So the symptom would have to be the headache, right? So essentially a headache that's reproduced with head or neck motion or head or neck positioning, it's not a cardinal sign, right? Because essentially, again, if you get a cardinal sign, some sort of cranial nerve sign, ataxia, lateral nystagmus, perioral paresthesias, all that sort of stuff, you're not doing any testing. The tests are over. As soon as you get that sign, you're done. They're going to the doctor instead of going through an exam with me anymore. So cardinal symptoms, those sort of things, cranial nerve signs, ataxia, quadrilateral bilateral paresthesia, perioral paresthesias, lateral nystagmus, those sort of things, those are cardinal symptoms. Those are things where as soon as that pops up, the examination is over. So at that point, I wouldn't be testing for vertebral artery stuff because I've already had the positive for an upper motor neuron sign. So at that point, that becomes relatively a moot point. But you can have non-cardinal symptoms that are present because of vertebral artery issues. Dizziness is probably the most common one. Having a situation where there is no dizziness really knocks vertebral artery compromise down the list of things that I'm concerned with. There have been studies that suggest that every documented case of vertebral artery compromise was associated with dizziness. I don't know how valid some of those studies are, but that has been a suggestion in the past, that if you don't have dizziness, you don't have to worry about it. I wouldn't go quite that far. But again, you have to look at the presenting symptom and decide, is this one of those symptoms that I would expect to be present based on a vertebral artery compromise? And there's modified versions of vertebral artery testing that you can go into for a patient like this. Now, this, 2 weeks out, you still consider this an acute patient, right? So you'd probably be going through a full acute cervical exam, which includes looking for things like fracture, looking at things like vestibular dysfunction from a perspective of dizziness, things of that sort of nature. And headache certainly falls into that realm of possibility. But unless you're actually producing some sort of cardinal symptom with your testing, you can document that vertebral artery testing was done and was negative. From a medical legal standpoint, that's great for you. It's not necessarily, a good thing for the patient if it happens to be there. But I wouldn't suspect in this particular case that that's the situation, but you need to do something that you can put down on paper.
Yes.
Modified declines is probably the easiest thing to do. Put them in the position of the treatment that you're going to use. So if it's manipulation, you put them in the position that you're going to manipulate them in, and then you do some sort of brief neurological exam in that position, right? Have them follow your finger with their eyes. Have them count backwards from 10. Have them stick their tongue out. Things like that, which got to be a lot more difficult when we were dealing with having to wear masks all the time in the clinic. But anything that you can do to test out some of the cranial nerve mechanisms, have them smile, have them raise their eyebrows, have them furrow their brow, that sort of stuff while they're in that position, you can be pretty certain, and I say pretty certain, that you're not putting them in a dangerous position to do the technique. Now, here's another question related to vertebral artery problems in this sort of scenario. The most common vertebral artery injury is intimal tearing, right? Tunica intima is the internal layer of the artery, and it's the same of any artery. But basically, the most common damage to that structure is you tear that intimal layer. And what will happen is the tear will clot, right? You get this buildup of an embolus up against where that tear is, where essentially where it was bleeding from, right? And so the concern is as you do a high velocity technique is that you rip that clot off of where it is, and it's going to go up into the circle of Willis, and that's where it's going to cause your major problems. How long does it take for one of those things to resolve in an average healthy individual? And I'm not going to wait too long, 6 weeks.
Yeah.
Right. So if you're really concerned about doing a manipulation on somebody that's had a trauma, somebody like this patient we've been talking about, then you just wait 6 weeks to do the technique. 22-year-old, healthy, non-smoker, no blood pressure issues, no history of clots, no history of bleeding. You have to consider things like birth control in a female. odds are you're in pretty decent shape here, that the healing process will still be around that 6-week period. Now you get somebody, a 45-year-old male that comes into the clinic that's a heavy smoker, that's had prior injuries to the neck, that has blood pressure problems and is on blood pressure medications, maybe is even diabetic, things like that. That 6-week time frame suddenly jumps from 6 weeks to 8, 9, maybe 10 weeks before you're feeling real comfortable about the healing process of that sort of vascular tissue. So just little things that you have to consider, when you're going in and doing this sort of stuff. So I've had this in the past where I just haven't felt comfortable doing the manipulation right off the bat because the patient just didn't match the profile. Like I said, they just had other extenuating circumstances in their subjective in their presentation as a person that just didn't make me feel comfortable doing it. So you just wait. You work on the other stuff. You're probably going to have some things in the upper thoracic spine you can deal with. You can do some modalities. You can do some, mild strengthening, things like that to try and get things stronger. But, eventually it may need the manipulation. You just have to wait until the time frame is right for you to feel comfortable with it. So that is always an option. It's not always the best one for the patient because a lot of times they're just like, this is driving me nuts. And I like the one that's most common for me is somebody coming in, they're like, I got to travel for work. I woke up with this kink in my neck and I can't get rid of it. That's non-traumatic, right? So doing the manipulation for that person is no problem whatsoever. But that's more common for me to see because that's just the population that I deal with. So again, vertebral artery stuff, I'm assuming you'll probably cover that quite a bit during this next module.
Yeah, 2 and 6.
2 and 6, yeah. So you'll get a lot more of that sort of stuff still to come. I have, Dave, if you want, I have a whole process outlined on a document if you want me to send that to you.
If you want to kick it over, that'd be great. I know I generally kind of teach them, Jim's process on the modified declines, but it'd be great to see what you're doing.
Yeah, that's what it's based off of, is Jim's stuff anyway. So
you tend to boil it down pretty nicely.
Yeah, so I can send that over to you.
So there's a couple more here. Like this we can skip over because we can follow the illness script on that one. With severe plain splinting, you see something that looks like a disc at that point, then you are probably thinking, okay, disc versus fracture. Either way, it's not such a good scenario.
No.
If it happens that quick. Muscle strain. Your Tanner, you got that one. I think Drew is looks like he has dropped off. Real quick, how would a muscle strain look?
Went running for the hills.
Like from a subjective standpoint.
Yeah, subjective testing.
So subjective, I'd probably say like moderate pain, more with like activation of the muscle. So like if you're looking at objective testing, tenderness with muscle, palpation of the muscle belly, weakness, and probably like some hypertonicity if it's just like a partial tear. I'd expect probably like more of like a increased resting tone.
And I think you'd probably also have the pain more likely at the end of movement, right? As you're actually putting stretch with range of motion, as you're actually putting stretch on whatever the muscle fibers are.
Would you expect I guess for this one, I'm just kind of curious for this one. Would you expect more pain with like the active, or would like the active end range, or like more passive, like stretching?
Depends on the severity of it. Give me 1 second, John. I'm just on a call. Give me 1 moment. It depends on the severity of it. So with active motion, if there's a more substantial tear to the muscle fibers, you can get it at the end of active, but you definitely expect it to go worse with the passive overpressure, and then certainly to be worse with resistance going back the other direction.
Yep.
All right, I got to jump off because I've got a patient just walking in. So
Hey, Eric, great job. Thanks a lot.
Yep, we'll catch you guys. Am I around? Yeah, I'll be around next week. So
good. All right, cool.
See you then.
Last one here, last 2 minutes would be concussion. How would you differentiate this from concussion?
Concussion's not my strong suit.
What tells you it's not concussion? Like you see this patient there, you never even mentioned it. So just think about why did you not think concussion?
More like the pain like I guess just like the overall patient presentation regards
Yeah.
like to pain, local, like the pain area, description of pain, aggravating, easing factors. Those things would make me think it's kind of rule that out.
Yeah, and that's where you look at, okay, there's no dizziness, there's no fogginess, there's no photophobia, phonophobia, anything in there that's usually more indicative of something like that. Like, sometimes it gets vague if you get upper ligamentous strain, it gives you you get concussion-like symptoms, and it's differentiating, okay, is it upper cervical versus central? If you want to test it, certainly different ways to test it. There's like, SCAT3, I think it's SCAT5 now they're up to. And then you also have, VOMS testing. If you look at, vestibular and ocular tracking and symptom provocation in those individuals. So like, VOMS test, it should be fairly unexciting if you're looking at, gaze stabilization, canceling, saccades, VOR, all those should be fairly normal and not really stimulate the cervical headache that you would see. Convergence, I don't expect to see that. So for whatever reason you got knotted up in this, you think, okay, well, geez, is it upper cervical strain or upper cervical concussion? By seeing that, you should have a relatively negative test with all those as well. If we're looking at upper cervical concussion, but you're right. It's like that is, pretty far down your list, but I wanted to kind of get an extensive list, like much like Jim in the presentation with the elbow did this. I thought since we're rolling into cervical, this would be a good time to take a look at it, because what other conditions other than pathologies, did we miss in this list? Does anybody have any other conditions where if you thought, man, what are the top things we would see in the cervical spine? What would they be in this case? Or in 80% of what you see in the cervical spine? If you have laryngitis like me, then put it in the chat room or spit it out. What do we miss? What are we missing here? Even if we have go as far as to say, okay, hey, do we have a sensitization case? This is a peripheral or central sensitization. Kind of early for that, doesn't match a model. Low percentage of people really have that. It could be a little sensitization, but then it's usually associated with the pathology being this far out. So I can't even put that in here. Maybe in my etiologies or my things I look at down the line, but not my differential. So this is essentially, it's good. This is kind of an example of, where Tanner hit it right away. I would think, joint inflammation, next would be a segmental dysfunction, just where Tanner was. And in my bias correction, I'm going to go through these list of things, compare them to there, and I can, in my exam, I can test for all these things when I look at range of motion, strength, ligamentous testing, Enfields, pivotums, and pavlums. As I get all that information rather quickly, I can organize my information into these different buckets, so that in my bias correction, I know that, hey, this isn't a cervical ligament strain because I tested it and it's not presenting like that. Muscle strain I can rule out through palpation and resistive testing. I can differentiate segmental restriction versus hypermobility. The disc herniation, probably if it's acute disc herniation, severe pain, severe limited range of motion, potentially probably radicular symptoms. It's going to be screaming at me for the most part, unless it's a smaller tear, which would be harder to differentiate. Joint inflammation, very likely. Concussion and fracture, we're going to see different symptom sets with these two. Fracture, severe pain, splinting, rapid onset, maybe increased later as inflammation came in. And concussion, as we talked about. So it's kind of cool because it's just about, how do we frame this in our mind when we look at the differential process? And in my mind, you have all these different buckets. And though my mind goes right to the immediate ones where I think it is, in my examination process, I go through the process of ruling out all these other things with my exam, but then also searching for other etiologies or other things that may be contributing to it. Cool, does this make sense? So